First of all, we're absolutely delighted you wanted to come and visit us. For us, it's incredibly important that the community knows that we're here, we're your resource. We're funded by everyone that pays taxes and dreams of being able to access really good quality care without any impediments from your gender, your race, your class, your money. So that's crucial. We need transparency. And when we were doing a redesign, my idea was that we wrap the whole building up in butcher's paper and have the whole community come outside and say, what would you like to see in this space? Because I actually think that we need good ownership. We wanted to just give you familiarity around what our services are, and they're currently always evolving. So at the moment I'm on a bit of a money fest quest. So anytime anyone's saying there's money around, I'm putting in ideas, we're all putting proposals in to be able to bring as much as possible out here, which is where it's needed, rather than other areas where perhaps people are much more of the squeaky wheel ilk, let's say. Gail wants me to speak to you a little bit about current trends, local and national, and of course, all anyone wants to talk about now is ICE. So I will say something about that. Our service is purpose-built, so if you have a look, we've got fantastic facilities, which is the first thing that greets you when you come through, because we very much want people to respect what's essentially a series of health harms that can happen to you if you misuse substances, and that includes alcohol. So, first thing is, this is not some sort of divey facility where people are going to feel really ashamed and coming from that idea of moral failure. This is nothing like that. We want people to feel that they can come in and actually recuperate and get well. Addiction medicine is the speciality that led the creation of this service, and it's a speciality that examines the harms and impacts for a patient, but not just the patient, the family, the community, and the health system. So when you get to know our team, you'll see that we don't just stop at one doctor talking to one patient, but rather with the recruitment of an amazing ALO, will involve the Indigenous community, with people that work within Justice Health, will involve the drug courts and the merit system, with our partnerships through our social worker being incredibly active in the homelessness hub, will involve people that are out in the NGO sector. Glenda and Phil are our Who's West representatives, so that's a direct partnership with people that provide ongoing care in the aftercare section. So for us, we're like a little hub and we direct out. We know as well that there are a huge amount of harms that's cascade from any one individual's use of a substance in a way that's absolutely and utterly health destroying. So think of us like the flying ninjas. Clearly you look at that and think that's just Gail and I. Keep going, Gail.
I'm in red.
You're in red, I'm going blue. And we're ready for action. We're delivering multi-layered interventions. Health promotion is the first port of call, so this day is the huge culmination of work that's been put in by Brendan Bennett and Kylie Druitt and the health promotion team, who have worked tirelessly to say, do people know we're here? They'd like to come and hear about what we do. People would like to visualise where they put their loved ones or their family members, or they actually refer to. They'd like to meet who you're sending your person to. So that is very much the driver of the day. And certainly there's so many myths and misinformation out there about drug and alcohol use and drug and alcohol use services that we wanted to actually counter some of that. We have support and embedded outreach clinics in diverse settings. So my counterpart, Judith Fraser, who's out there, runs our consultation liaison service, which is our ninja team up to the hospital. When anyone says, hey, that person's actually expiring in their bed because they're a known alcoholic, even though it was 20 years ago and even though they're actually probably bleeding on their brain, we send our ninja in to say, hold off, this may not be the case. And likewise, if indeed we begin to see something that's compromising an inpatient stay because a drug and alcohol issue has not been acknowledged, the same thing happens, we go the other way as well. So that's a really interesting part of the service that contributes to actually embedding good practice within the 1 in 5, that's the latest idea, probably 1 in 4, hospital stay admissions that are complicated by some sort of drug and alcohol misuse. So when you think about it, that's an enormous amount. And then if you think you went to a respiratory ward, imagine what tobacco is doing. And we also have huge input there. We liaise with governments and community organisations. We provide information of all manner of substances and actually give ideas around the ways this may cause harms. And we're certainly listening to people because those harms are evolving. The uniqueness of our ward is that we're 15 beds. They're extraordinarily well built and they're incredibly respectfully designed, which is really important. dedicated to providing care for our patients who are struggling through withdrawal. And each substance has its own particular, unique way to lure, seduce, convince you to use it again and again, and to minimise its harms when it's saying to us, you know, it's not that bad, I can come back into your life, it'll be okay. Next. So, alcohol remains the most medically dangerous. Betray my British origins. Anyone here know who that is? So that's George. Well done, George Best, who begged everyone to use his picture on his deathbed and said, please use this to remind people what it's like to die from alcohol-related disease. Now, this is a gentleman who went through the full gamut of treatment, including having anti-abuse rods inserted in his liver, and he drank over and on top of it. Genetically loaded, came from Ireland, had a mum that died from alcohol-related disease, played for Man U, best player ever, but never reached full capacity, never became the people, one of those players that we think about like Pele or Maradona or now Ronaldo, because we lost him. So for us, it's about trying to capture our sense around how do we restore that lost potential. So it's incredibly important to us. Next. Say it's not so, doctor. I drink 1 glass of red wine each day for my health, and the rest of the bottle is because I like wine. Doctors are absolutely appalling at managing alcohol, because when we make money we tend to invest in vineyards. So for us, we're never quite sure about saying to you that alcohol causes harm, and I know that our new nurse manager would certainly agree with that. And really interestingly, this little syringe, it came from a doctor who came up with that in the US, that it was a way to say to someone, after you're having an injection or you have some sort of medical procedure, go relax yourself with a glass of wine. So, you know, doctors had a huge role in promoting Camels and cigarettes, and now equally we're promoting alcohol because we just love it. Keep going. So what others do we look after within this ward? We have looked after with patients who have struggled with heroin, your good old-fashioned mainstay, cannabis, fly spray. Fly spray was a really interesting one. Barely anything written about it in the literature. It was quite a big headspin that came from the youth service, because they can certainly bring you some incredible clients that use some amazing substances. Codeine and Nurofen Plus is a real growth area. Beautiful for the lady that wants to take a bit of a holiday without anyone noticing, so you can get a nice stoned feeling if you're chewing down 2 packets of Canadine a day. You can rotate your chemists. You can also have a very inconvenient gut bleed, which tends to be absolutely catastrophic. Street drugs, which are constantly emerging, so the UN has a tracking system about all the new illicit substances that are developed each year. They change all the time. I think the novel psychoactive drugs, they had an absolute change from identifying 70 unique compounds to over 356 the last time they had a look. This is a growth market. Anyone that's watched Breaking Bad, who's watched Breaking Bad, anyone that's done high school chemistry, of course you have, anyone that you can use the internet, we all believe we're great chemists. Dr. Google, much better than me, Dr. Oz even has been knocked off. And the health harms that have arisen are as endlessly and insidiously varied as the combinations themselves. So it's very much for us about understanding what patients are telling us. And people will say to you, surely it's just a matter of willpower. Actually, the newer science says that that part of the brain is stopped from being the arbitrator for this decision. So the decision lights up before, base brain, before it even gets to your higher centers. So whatever you believe about you actually consciously choosing it, not true. Who here drives the same way or walks the same way to work every day? Do an experiment. I do it. Automatic. Anyone found themselves on a highway thinking they're coming to work? That's my life every day. What happens when you deliberately change that route? Your whole brain, your whole body feels incredibly weird. It's like, why are you doing this to me? Why are you tormenting me? It's something so small, but it gives you an insight into how rotten we are when we're saying to patients, just say no. Because their entire priming is towards, but I'm automatically going here. I'm not even thinking about it. How can you possibly say to me, just say no? Then there's the big question of genetics. So it's, yeah, maybe for some substances is what I'd say. I'd direct anyone to have a good look at twin studies. So these are hideous things that doctors did where they removed children, which is appalling, and split up twins. So they're brilliant cohort studies, aren't they? You have 2 identical people, genetically identical, put in 2 different environments, and then you watch what emerges. So how much does that environment contribute to whether or not you become a drinker, particularly? Yes, it has some role, but you know what? It doesn't explain everything. Certainly now, with newer understandings about genetics, so has anyone bought Norman Doty's book, The Brain That Changes Itself? Did anyone read that? Did you love it? Did you get really fascinated with neuroplasticity? And that is really interesting for a drug and alcohol worker, because you're thinking, what can I do to swap around what you're using? And for people that work with younger clients, even more important that we get their brains incredibly plastic and moving around. So, other people will say, well, just don't start. But all of us start sometimes. Did anyone drink coffee at 5? Anyone drinking coffee now? You all started. Well, well done, well done. Anyone ate chocolate when you were a 3-year-old? Probably not. Now, you never ever make that decision. And you know, when you think about it, within the Drug and Alcohol Involuntary Treatment Act, one of the prescribed substances I could theoretically say that you had destroyed your life over is caffeine. You should never have started with the Nescafe. So the answer is much more complex. Much of it has to shift beyond the idea of us only looking at you when you're being ill, and being much more towards how do we make you well and healthy. Anyone ever been to a doctor where they spoke to you about, I'd like to make you healthy? No, we're really good at categorising and cataloguing every inch of you that's sick. And if you don't feel unwell when you went in, you will by the time you leave. So, our services have been aimed towards helping that. This is poor old George Best before he travelled that horrible journey to being a very jaundiced gentleman in his bed. And he said, people say you have to hit rock bottom. And I can tell you, almost dying as at rock bottom as it gets. And for me, the biggest tragedy you can ever have is a cemetery where you're visiting a gravestone because you weren't standing there because you were waiting for them to hit rock bottom, or they were too scared to come and tell us about what they'd used or what they'd ingested. That is a disaster. End trends. Okay. New patterns of harms among the young. So what are the new patterns of harms? Well, you know what? Young people are pretty damn good. We said to them, when you use alcohol, don't drink every day and don't drink in the morning. They obeyed us to the letter. Now they drink after 5 on a Friday. They always stay abstinent Monday to Thursday, and they ain't drinking in the morning. Thank you, doctor. We just happen to have this huge amount of harm that's coming from binge drinking. So that's not a good one. We turned around and said, just don't get addicted to one substance. Excellent, doctor. I'll run out and I'll use many substances. So I often stand at the ward and say, oh, for the days of the brand loyal heroin addict. Those days are gone. People are creative and they use lots of different drugs. Certainly, there's many, many more complex and embedded adverse social determinants of health. So if I had to pick up my poster boy, it would be Sir Michael Marmot, who's, a very, very crusty Englishman, who has actually watched people over 40 years and said, if you're born in a cold house before 5, you're so much more likely to develop depression as an adult, even if everything in your circumstance changes. Now, what's not happening within our current funding models is we're probably not really good at having a look at how we're going to help this. Anyone here ever had to organise housing for a patient or a client? Has it been fun? Oh no, it hasn't. And when you're turning around saying to someone, if you're with my begging letters, and believe me, having a British heritage, I can beg like anyone, when you're really, really going for broke and saying, please, this person's whole health, their whole way of life has been impacted upon because their housing is so appalling, and you've got a 5-year wait, I think that's an awful lot to say to them, oh, and don't drink, oh, and don't use. Because if that's your only bit of pleasure, and you feel so insecure everywhere else, that's a really big thing. So one of the things that we're doing is we've got this really good student who's able to geographically map areas for us. And one of the things I'd like us to be able to contribute to is mapping out what we know happens. So I know all of you know which block of units within Penrith, and particularly in this area, involve a fair amount of drug dealing. That's really hard to send someone who struggled on our ward back to the same place. Glenda faces it even worse. So Glenda will take people to Who's at Roselle, keep them for a period of time, and then what happens, Glenda? We send them home. And then we get really cross at them when it all goes wrong. And we say, but we invested 6 months in you. We did this for you. Yeah, but you didn't change what was happening for me and where I'm getting triggered to start with. So, what is this? Anyone know what this is? So famous. So this is the iceberg that they think hit the Titanic. Okay. Now, one of the things about the iceberg that hit the Titanic was that there was a ship in that area who saw fireworks going up, the Californian, and the captain said, they're celebrating, they're having a party, they really don't need our help, as the ship sank. I think it's a really good metaphor for what happened with ice. We watch the fireworks, and all of us that work in health and read epidemiology and read national surveys and look at what's going on said, they're okay. It's just the same group of people having the same group of harms, they're just using a little bit more, it's intensified, they're having a party. We, health, were very much like the staff on the Californian, because what the people were trying to tell us, and certainly communities were trying to tell us, and our patients were trying to tell us, actually this is a little bit different. And I think the worst mistake you can make if you work within health or any sort of clinical service is not listen to your patients. So ice. The community saw something, and we were the staff, and we insisted the evidence wasn't saying this, and it wouldn't impact noticeably, and then we had to begin to listen. And we needed to listen, and we began to watch. So what did we see? We saw a proliferation of people preferring a more crystalline form. If you don't have much money, if New Start is under threat, if you can't get much, and you get more bang for your buck, I do it. Who shops at Aldi? Who's bought it down Murphy's? We've all made exactly the same decision. It's just that some people have to make it about drug use. And don't talk about an alcohol tax when you can pick up $1.99 bottle of red at Dan Murphy's in its bargain bin with 8 standard drinks. Awesome. Daily updates across the media, the ice age, the ice epidemic. It didn't matter how much we said to people, please don't talk about ice, please call it methamphetamine, no one listened. Concerns were raised from all different sections of the community and in really new ways. And what was probably the bit for me was sitting in our opiate treatment clinics where our patients are incredibly experienced at using drugs and having those patients say to me, I am so worried about my daughter. Now these are not people that are drug naive. These are people that have seen all sorts of things and were saying that this is a little bit different. So it wasn't our own sector that raised the alarm. It was the police, community and emergency departments, much as it was elsewhere. So what we had was Ken Roney saying that all the time I've been a policeman, which is 41 years, this is a huge scourge, it's horrific, it has the potential to destroy generations. I don't know that that's because he's saying it's necessarily impact of the drug itself. Like there's nothing particularly toxic in the sense of tobacco or alcohol in terms of the cumulative effects are going to be appalling. But if you have something that already gets into an overcrowded boat, adverse social determinants, very tired people, people under stress, it's going to be the one that sinks the boat. This is really interesting. The average ice user, even if they're skinny thin, have superhuman strength. No, they don't. They just don't realise they're getting hurt. Anyone that sees someone who's supposedly demonstrated superhuman strength 3 days on, they got the bruises, they're really tired, they ache all over, it's not superhuman strength, you can't remember what's going on. Now, those who have worked in drug and alcohol for a long period of time, that happens with alcohol as well, because anyone that's drunk will walk on a broken foot. They'll wake up. It's the same thing, it's just that it's a little bit more frightening in this context. From emergency, there's a huge degree of concern because they feel intoxicated patients are not well managed in their sphere. Okay, now with huge respect to people that work in emergency because they do an incredibly difficult job, but when you say to them, how many people are you talking about? At least one a day. So what is it about that one a day that's causing you such distress? And how are you identifying it? And what's happening to you that's making it really, really difficult to manage? The use of restraints is increasing, and that's not necessarily driven just by the presentation of the patient, but people in health work on pattern recognition. We become unconscious professionals. So then if we read no nice user, we see no nice user, and we see recourse to restraints, and we don't necessarily see actually perhaps ice use, also DKA, diabetic ketoacidosis, also cardiac event, may not need restraint. And that's where we're all getting a little bit worried about one another in terms of how well we're managing this group of patients. So the New South Wales Government has committed to fund lots of innovation in this space, and again we're putting our hand up so that we can actually try and do something a little bit new. So, really interesting disease. in Italy called fatal familial insomnia. Has anyone heard about it? It means you can't sleep. So you have a protein that goes wrong in your head, and you begin to lack any ability to sleep at all. What's really interesting about that set of families that express this gene, they almost look demented and septic before they die. And if you think about people that are using methamphetamine who can't sleep for a long period of time, that's very much what they look like when they get to ED. So perhaps there's some clues in the way we manage that group of patients to inform how we care for this group of patients. So contact to all areas of our service. People are describing family breakdown. One of the really, really disturbing things about methamphetamine, and it's hidden in the neurological literature, is that it seems to tip people into an OCD type behaviour. So if you're a carpenter, that's, neurologists are pretty daggy, that's what they describe. If you're a carpenter and you use methamphetamine, you make absolutely over and over and over again. It's called punding. So you see it in some forms of dementia and Parkinson's. What if the punding is the actual ice use itself? What if you're tipped into going over and over and over again to use the methamphetamine without being aware of it? The aggression and violence, and from the patients themselves, if this is a very different drug. I'll tell you how different this drug is. If you actually chase the literature through the United States, when it hit indigenous communities, and this for me is incredibly worrying, it had a disproportionate effect on the way in which their young men suicided. That is scary. That's much more scary than the violence and aggression, with huge respect to anyone that gets hurt. I get that. But violence and aggression, you often recover. You don't when you're dead. And you don't when you're a young man, so it's scary. So, our concerns, we want some clarity around the extent of the problem. We certainly want to reframe the discussion so that we can have some understanding reflecting that health and community services involved with delivering care do have treatment options available. So, amphetamine substances are the second most popular generally. They're in big surveys, likely to be the drug that's first injected, so that's got big implications for us now, that if we do have a whole cohort moving on to injecting behaviour, that's not good. Got a lot of physical side effects, so what people don't talk about is what happens to your heart. We've had a spate of people that have come in through the ward who've got cardiac effects from their methamphetamine use. That's pretty scary. And there's disturbing trends in production in terms of people within the African continent beginning to have meth labs, which means they're a good distribution network for us and also Southeast Asia. So that comes out of the UN data. So there's these really interesting things that you can get onto in the UN global novel substances and drug websites. Walter White from Breaking Bad. Police data say there's lots of big halls because it's easy to use, and in Australia we tracked the emergence of this from earlier surveys, and we have actually had three spikes that we've been expecting, but this is the one that's hit, so there's probably a lot going on socially that's changed it. Why it's crucial to address this question: for every social context and in every time we get attached to a particular substance. So after World War II, smoking was fantastic. Who here turns their phone off at night? Oh, well done, Lily. Go on, we can all confess. Who does not turn their phone off at night? Who is constantly beaming in to the rest of the world as if it matters what I think when the Guardian tells me at 3 o'clock in the morning that it's changed its headline? Yeah. This is a great drug for us because we're up the entire time. This is the drug we were likely to fall in love with. I love being awake. I have this horrible sense I'm missing out if I'm not connected. I have no business knowing what people are telling me at 3 o'clock in the morning, but I delude myself in feeling that I have to say something. So we're living in a constantly switched on, endlessly present society, especially if you're young. So anyone here that's parented or had anything to do with young people, biggest catastrophe is when someone's got a really, really upset friend at 3 o'clock in the morning who wants to text that teenager right at that moment, complete without context, complete without physical awareness. That is disastrous. And that's what we're doing. Of course we love this drug. Everyone wants to be a witness all the time. Remembering that after repeated drug use, deciding to use drugs, any more than deciding to use your mobile phone, deciding to change your route to work, deciding not to have coffee, is not always voluntary because they change the brain. So, patterns of use, this is not necessarily dependent. So one of the things we struggle with is that people will ring up and go, I have a really big problem with ice. Okay, how often are you using? Oh, every weekend. Well, you know what? We fund wards and we fund medical wards particularly, having the idea of dependence, which suggests a 20th century version of addiction. You must use it every day at greater and greater amounts. You must show me withdrawal. But what if you can't manage 4 days abstinence? What if you can't manage more than that? There's an awful lot of people with alcohol that can't do it. And if you listen to the public health campaigns around alcohol, people move towards have 2 days straight, now towards try and not drink on Fridays, Saturdays, because we know that as much as we educate the public, everyone says, yes, we get it, and then they change their behaviour and we introduce a new harm. Who here drove today? Yeah, have you all been in a car accident? God forbid, no. Of course you have not. But the time that you don't wear your seatbelt, you accept that it's catastrophic enough that you need to wear it. We need some of that thinking around drug use. Keep going. So just a couple of examples for us. We had a young girl who was 17. She graduated from fax care. She was identified at hospital 7 in our hospital files. We went back through the hospital file. Her mother was heroin dependent at that time. So as a little 7-year-old, she's the reason she's got an entry in our hospital file is that she's gone into a social work negotiated extra bed in a ward while her mother is being looked after. And they incidentally find during that time that there's no electricity and no food in that house. Now she comes back to us at 17, she's been in and out of foster homes, her mother's died, she's homeless. You know what? Methamphetamine is a really good way to feel protected when you're living and sleeping on the streets. Next, JS, who's a hugely successful story. She was using daily, pipe only, got her through university, really nasty case of ADHD when she was a child. When she was actually working at uni and can have this $50 smoking a day, great. Has a shocking problem with night terrors and significant phobias, feels safe and invincible with ice at her side. Huge success story because she went through the stimulant treatment clinic protocol that's done through St. Vincent's, worked really hard on using one of the new medications as a substitution, did incredibly well, so much so that even when she lost her boyfriend to overdose, she stayed well, she stayed abstinent, she went on to meet someone and she's now a young mum with a 1-year-old, which is really sweet. SW, another gentleman who came onto our wards, playing rugby league, he was going to have the dream life, he was a great player. At 16, after a try, a player jumped past his neck, just nicked his neck. Wasn't big, wasn't one of those ones where you got airlifted, but nicked the neck. Had a huge carotid aneurysm that evolved over the night. So you got 3 months in a contact halo, that particular neurosurgical hell where you got all the bolts into your head, no more contact sports, he's bored, he's sad, he's unemployed, his whole life's over, but he feels really normal when he meets his mates and he uses methamphetamine. So the young are not convinced by scare campaigns because the harms do not become the faces of meth. That is an appalling campaign that only Americans could have come up with. They're not seeing morbidity or mortality, and they're not reviewing it as a health issue. For them, this is entirely different. So we need to get the message out around the changes, and we need to start saying to them, there are some real big physical harms we need to make you aware of. Not you're going to look like, I don't know what, in Texas. You're irritable, you're aggressive, you've got a hijacked sense of pleasure. So you know one of the really good ones is to start telling young men they won't manage an orgasm soon if they keep that up. A persistent drive to use. We used to use man boobs and alcohol, another great one for men, they hated that. And also shrunken testicles, an oldie but a goodie. It's not a choice being made, it's actually affecting a very base part of your brain. And I think telling people that is important. So, in our little part of the world, we can offer you treatment, we can offer you information, we can offer you clinics, and we can offer you advice. And we welcome all your visits. Thank you.